We are going to get started in the interest of anyone who's watching online. My name is Rona DiCamillo. I serve as the Vice President of the League of Women Voters of Jacksonville First Coast. Our league covers here in St. Johns County as well as Duval, Nassau, and Clay counties. The league is a nonpartisan organization. What does that mean? It means that we don't endorse candidates or parties, but we do take positions on issues, so that does make us political in that sense. Our goals are education and advocacy, and I can't think of a better topic for us to participate tonight in a town hall than on healthcare. Our speaker this evening is Dr. Dawn Francis. She has been a physician for over 25 years. She has experience in clinical medicine, the healthcare system leadership, as well as healthcare payment policy here in the United States. She brings a practical, nonpartisan perspective shaped by decades of work at the intersection of patient care, health system operations, and healthcare payment policy. Just a little note, on your chair, there should be a 3x5 postcard. That is if Dr. Francis says something and you think, oh, I have a follow-up question to that, write your question down here. And at the end of her presentation, someone will come around and gather the cards, and we will get through as many of the questions as we can. So without further ado, Dr. Dawn Francis.
Thank you. The thing is, we're all fragile and finite. And there will be a moment in all of our lives when our survival is dependent on the help of another human. The famous cultural anthropologist Margaret Mead was asked by one of her students how she knew she had come upon a civilization when she was doing an archaeologic dig. And the answer was, she knew she had found a civilization when she found a femur fracture that had been healed. Because if you're a hunter or gatherer and you break the largest bone in your body, it's a death sentence. And only when you can be pulled aside by one of your fellow humans and sheltered, and they share their resources with you of food and water, only then will your fracture heal and you'll survive. My friends, we belong to a sophisticated civilization, one in which we have poured enormous resources into the technology to be able to know exactly where you broke that femur. The picture without the intervention, I can't tell which side it's on, I'm sorry, is a femur fracture, a fracture of the femoral neck, a hip fracture. And a third of all women in the United States will have this fracture in their lifetime. And we've invested technology to not only be able to visualize that fracture, but also to be able to heal it and to make it better than new by putting in a hip prosthesis, a hip replacement. And not only have we invested money into this, but all of the providers that are coming together for this have invested their lives. Their nights, their weekends, their holidays, their missed birthday parties, not only so that they can learn, but they can practice this form of healing. The radiology technician, the radiologist, and the team that will come together in the operating room with the scrub nurse, the anesthesia provider, and the orthopedic surgeon, and they will heal this hip fracture. It's miraculous, truly. And it's also costly. And how much it costs depends on where you have this hip replacement. For example, if you have your hip replacement in Chicago and you have commercial insurance, it will cost 50% less than if you have it in Atlanta. And government payment, Medicare and Medicaid, will pay the hospital half as much. And if you have your hip replacement done in the United States, it will be more expensive than anywhere else on the face of the earth. And it's not just hip fractures that are expensive. In the United States, we spend on average twice as much per capita as any other country in the world. In 2025, that was $5.3 trillion. And if the amount of money we spend on healthcare was gross domestic product, it would be the third largest economy in the world. It would be tied with Germany and only behind the United States and China. It's an economy itself. And you would think that with all this money that we spend on healthcare, we would be the longest lived and the healthiest humans on the planet. Now, I will acknowledge that it's difficult to measure the health of a nation, partly because we don't measure disparities, because we measure health of a nation as one nation. And as one nation, one measure is life expectancy. And we are not the longest lived. In fact, the life expectancy in the United States is lower than any of our peer countries. In the United States last year, it was 79, and for Japan and Switzerland, it was 84. And it's not a mystery. We actually know what accounts for those 5 years of difference. 1.5 years of that is due to premature death before the age of 50, and that's because of mainly drug overdose, motor vehicle accidents, and gun violence. Another 1.5 years of that is due to our lifestyle, being obese and sedentary. But 2 years of that has to do with our lack of access to healthcare and healthcare disparity. This is not the only way we measure health of a nation. Another common accepted measurement is maternal mortality, the number of women that die in and around the time of childbirth. And in this one, we are the best of the worst. If you compare us with this and our peers' average, we're 3 times as worse. And if you compare us to the best, which is Switzerland, we're nearly 9 times worse. And again, it's not a mystery why. There are vast maternal care deserts in the United States. So there is something we do pretty good at. This is chronic diseases and the portion of patients with these diseases that get admitted to the hospital in any given year. So we do better than other countries in pulmonary disease. COPD is emphysema, and the other is asthma. And the reason we do better is because we don't smoke as much as our peer countries. And the reason we don't smoke as much is because it's socially unacceptable. And the reason it's socially unacceptable is because of the hard work of a Surgeon General in the 1960s. But if you have other things like cardiovascular disease or diabetes, the most common chronic diseases, you're much more likely to get admitted to the hospital with an acute crisis in the United States. So who's paying for all of this health care? About 30% of it is private insurance, but that makes up hundreds of different companies. The biggest payer for healthcare in the United States is the US government in the form of Medicare and Medicaid, and CHIP stands for Children's Health Insurance Program. And then in the little light blue pie piece there is also the Veterans Affairs in the Department of Defense. So the United States pays last year over $2 trillion in healthcare. And I'm sorry for introducing this slide by saying who pays for it. It's you that pays for it. It's all of us. And some of us contribute to all pieces of the pie. For example, private health insurance is supplied to me by my employer. But that's my salary, that's my money. And I pay Medicare tax. And I pay out of pocket. This is your money. but the United States is rich. We can afford it, right? It turns out that in aggregate, US citizens owe $220 billion in medical debt. And most of that is people who owe over $10,000. And knowing what I know, even I was surprised to learn that 2/3 of bankruptcy filings are due in part or in whole to medical debt. So it seems like we can't afford it. And so if we have a very expensive healthcare system and we're not living as long as our peer nations and we're not as healthy as they are, why is healthcare so expensive? This is a complicated answer to a simple question. And I know I've got your attention for about 20 more minutes. So I'm going to take a complicated answer and target it to the things that I think are most important to understand. Most of the money in healthcare is spent on hospitals. I'm not going to talk about hospitals. The reason is that the other things I'm going to talk about feed into the expense of hospitals, but also hospitals are where the most acute care comes. It's where the most expensive things happen. Emergency departments, labor and delivery, surgery, organ transplants, the intensive care unit. We're not going to talk about hospitals. We're going to talk about other. $5.3 trillion and 24.7% of it under the vague title of other. And most of other is something called administrative costs, which is also a vague term. I'm going to walk you through some examples of what administrative costs are. I suspect all of you have seen this at some point in the mail. It's not a bill. It's an explanation of benefits. Now, as you heard in the introduction, I am a physician. I'm a gastroenterologist. And when I do procedures, at the end of the procedure, I create a procedure note. And then that note is viewed by a medical coder. And he or she looks at it and determines what the best code is that describes the procedure. It's called a CPT code, Current Procedural Terminology, created by the American Medical Association. And it's a different code if I perform a colonoscopy or if I perform a colonoscopy and I remove a polyp. And so then that different code is submitted to your insurance company. And ahead of time, your insurance company has likely negotiated what they will pay the facility for that procedure code. But one insurance company has many different plans. So what your out-of-pocket is different. And you get this explanation of benefits, and it's much more expensive than your estimate. Your out-of-pocket estimate ahead of time was $0, and now you owe $2,000. You thought it was a screening procedure. But a polyp was found, and so now it's become a diagnostic procedure. And so you're curious about that, and you're going to call your insurance company. And then the insurance company is going to say, I don't know, that's what the claim is that we got. Call the facility. And then you're going to call the facility, and they're going to say, oh yeah, it was a screening procedure, but a polyp was found, the point of the procedure. And it's now become a diagnostic procedure. But we'll ask Dr. Francis just to make sure that the way she's documented it is accurate. And then it will come to me and I'll take a look. I'll say, yeah, that's accurate. And all of that took so much more time than performing the colonoscopy. Administrative costs. There's another thing that I'm not going to get into right now, but I know it's all touched you, prior authorization for medications and services. We have fleets of people in the healthcare industry that handle prior authorization. It's an administrative cost. And I alluded to this before, but I'm going to pull on this thread a little bit. Hospitals negotiate the prices for procedures with each individual insurance company. And much of this was opaque up until the transparency laws. So now you can find this stuff, but you have to know what you're looking at. So if, for example, you have an appendicitis and you go to Montefiore Medical Center in the Bronx, your insurance company could have negotiated a payment of $1,900, or it could have been $63,000. And if your coinsurance is 20%, it's quite a bit different. In fact, 32-fold different. And how would you know that ahead of time? I mean, I guess you could look if you know what you're looking at in the internet, because the hospitals publish this. But why would you look? Because you're there with an appendicitis. All of this to negotiate all of these different payments for all of these different procedures is administrative cost. Why do hospitals negotiate different prices for the same thing? Well, they're allowed to, and also to some extent, they have to. This is a healthy financial picture of a hospital. On the right, well, my right, I don't know, the bigger bar, it's on your left, I'm sorry, is net income or profit from commercial payment in a hospital. The red bar is net loss from patients who are uninsured, came in with an appendicitis, we have to care for them. For patients who have government payment, it's widely known that hospitals lose money on Medicare and Medicaid. And so if their bar on the left is high enough, it will offset the red bar, and then you'll get your net, which hopefully is in the black. This is a healthy picture for a hospital. If there's a hospital in an area that doesn't have very many insurance competitors, then their ability to negotiate the price of payment is limited. It's not competitive. And then it turns out that those same areas are the most vulnerable to loss of insurance. There's a change in legislation and they lose Medicaid. There's a closing down of the plant and they lose their employer-paid insurance. And so then that red bar becomes bigger, and the bar on the far right turns from black to red. And then the hospital becomes insolvent and closes. And when the hospital closes, it affects the people who are insured and uninsured. And if you happen to have a heart attack in the community and then you have to drive 60 miles to the nearest hospital, that's the difference between life and death. Administrative costs. The workforce in the United States is expensive. I'm going to pick on physicians because I am one. In the United States, physicians get paid on average twice as much as our peer countries. And if you compare us to the developing world, it might be as many as 30 times as much. Why do physicians get paid so much in the United States? There's a lot of answers, but here's one. There's not that many of us. If you compare us to many of our peer nations, we have a physician shortage. That's especially true for general practitioners. This is all physicians. Now, I don't know if you've been keeping track, but Japan had one of the longest life expectancies, 84 years, and they have the same number of physicians as we do. So they figured out how to deliver healthcare without physicians or without as many. That's for a different lecture, different day. Why do we have so few physicians in the United States? I'll tell you, when I applied to medical school, it was 3,000 applicants for 140 spots. And every transition in my career was more competitive than that. It seems like people want to be physicians. So let me tell you about physicians. In order to practice medicine legally, I need to be licensed. And usually to be employed, I need to be board certified. And in order for me to get licensed and board certified, I need to complete a residency and possibly a fellowship. And those years of training are anywhere between 3 and 10 years, 10 years being a neurosurgeon. And Medicare pays for that. And in 1997, with the Balanced Budget Act of the Clinton administration, the number of residency slots in the United States that Medicare could fund was frozen. And there's been some little legislative fix and benefactors, but essentially, the number of physicians that are available to enter the workforce this year will be almost the same as it was 30 years ago. And in the meantime, the population has aged and grown, and there is more demand for healthcare services. So the market is more competitive, and physicians get paid more. And also, we're doing more. And so it's expensive in money, but there's another cost. This from The Economist in December of 25. American doctors are rich and miserable. They lead the world in burnout. And it goes on to talk about the highest professional suicide rate, and that's especially true for women. You know we're burnt out, you've seen us. We don't listen. We don't connect. We're burnt out. And it has a cost that's not money. Prescription drugs are expensive. This could also be another lecture. I would really love to show you like 20 slides on pharmacy benefit managers, but I'll lose you. You know they're expensive. Some of you have purchased prescription drugs from Canada. I am aware of people that travel and will stockpile a year's worth of drugs because it's cheaper to do that than to procure them in the United States. Why are prescription drugs so expensive? Well, if you ask the pharmaceutical industry, they'll say it's because the United States citizens have enough money to subsidize research and development for the pharmaceutical industry. They will fail to tell you that their research and development funds includes marketing. They will also fail to acknowledge that the basic science and even at times the creation of the drug itself was already funded by the citizens of the United States through the National Institute of Health. But even if that's not true, the pharmaceutical industry and the medical device and the medical supply industry are all for profit. And it seems like a pretty good business. In 2003, the junior President Bush passed the Medicare Prescription Drug Improvement and Modernization Act. It created Medicare Part D. I think most of you might remember that. It was a good thing. But in the legislation, it prohibited the United States government from negotiating prescription drug prices. So you're spending your tax dollars on Medicare, and Medicare, the largest single payer of healthcare in the United States, cannot use its collective bargaining power to negotiate drug prices until 2022 with the Inflation Reduction Act under the Biden administration, which allowed for some drugs to be negotiated, and even with the Trump administration, some additional drugs. But even with the US Medicare negotiating prices, we're still paying more than other countries. And then there's this. I hate to pick on CVS, but they have a great graphic. And they're responsible for 30% of the prescription drugs in the United States. You might not have known this, but you are aware of CVS, your corner drugstore. But CVS also owns Aetna. And they also own the biggest pharmacy benefit manager, CVS Caremark. And they also own clinics and employ providers. So if it comes to pass that you got your dream job, and your dream job offers you Aetna, you don't typically have a choice, right? It's not Aetna or United or Blue Cross Blue Shield. You get Aetna. And on the weekend, you develop a sinus infection, and so you're looking for somewhere that's cheap and fast, and so you'll go to Minute Clinic because they're in your network. A MinuteClinic's provider will assess you and prescribe you perhaps an antibiotic. You can't choose the antibiotic. You're not supposed to. That's the point of a healthcare provider. And you'll get the prescription and you'll go to CVS because you're already there because you're at MinuteClinic. And you'll pay $20 copay for your levofloxacin that they've prescribed. And as a patient, this will seem like a good thing, maybe. Now, the levofloxacin actually only costs CVS $2, so the copayment of $20 is more than you'd expect. It could work great for you as a patient. It definitely works great for CVS. But it doesn't seem like an open market with competitive choice. I've explained to you that we spend a lot on healthcare, that we are not the longest lived or the healthiest, and it seems like much of what we have in healthcare isn't a choice. How did we get here? Well, it turns out that as medicine was advancing, the legislation came along with it. So from 1850 to the 1900s, healthcare was starting to enjoy a lot more understanding about how the human body works, what infections are. We're starting to play with anesthesia. And the administration of healthcare moves from the kitchen table to the hospital. And at the time, the American Medical Association was founded mainly to regulate the education and the licensing and credentialing piece. And countries were starting to think about how will we provide healthcare, or should we provide healthcare for our citizens? The same way they grappled with what will we do with the military? How about a police force? How about a highway system? In this time period, Germany had created universal healthcare. And now it really gets serious. In this 20-year period, we are giving anesthesia at scale. You don't have to die of an appendicitis anymore. We have sterile technique and antibiotics. And physicians moved from professionals that were going to predict what would happen to professionals who could change what's going to happen. And countries were considering whether the government should provide this type of care. You probably know the United Kingdom started with that. The legislators in the United States were grappling with this as well. And with the Progressive Party, with Teddy Roosevelt, they introduced legislation for a national health system. And now the American Medical Association had become politically active. And they registered significant opposition for fear that the government would dictate clinical decision-making. And so it was squashed. And then with the second President Roosevelt, in the throes of the Depression era, he has a New Deal. And the New Deal includes a national health insurance. And now the American Medical Association had become very politically active. And they have termed this socialized medicine, a term that sticks today. It was a particularly poisonous term because there was concern about growing communism in the world. And there was a conflation between the idea of socialism and communism. And so, as the New Deal was pushed forward as a legislative vehicle, the only way that it could be passed was if the National Health Service could be scrapped. And it was. And so the Social Security Act of 1935 did not include health insurance. Meanwhile, the titans of industry are realizing that a healthy workforce is good for business. They're more productive and it's more profitable. Henry Kaiser, who you see on the left, but probably don't recognize, created the first employer-provided health insurance. He was a business tycoon. His construction company built the Hoover Dam. You don't know that probably. But you do recognize that one thing he did that was very effective was to create Kaiser Permanente. which other businesses purchased and labor unions. And medicine marched on. Hospitals became a trusted place to go if you had a heart attack or a stroke or appendicitis. And now, vaccines cured polio, eradicated it, a visible and ugly disease. And what became apparent was the people that needed healthcare the most, the poor and the elderly, were the ones that were least able to afford it. A national health insurance had been tried by two Presidents Roosevelt, by Truman and Kennedy. And by 1965, there was a new president in the White House, a new feeling in the country, and maybe most importantly, a new president of the American Medical Association. And with that, the Social Security Amendment Act of 1965 was passed and created Medicare and Medicaid, the first government-provided insurance in the United States. And medicine marched on. We brought on CT scans and MRIs and PET scans, and it completely revolutionized how we could diagnose people, because now we didn't have to open you up to look and see what was inside. We had these tools. And that was expensive. And there was concern that Medicare would collapse under the weight of the expense of health care. Medicine marched on. Laparoscopic surgery became the norm. We were transplanting organs safely and regularly. We introduced biologic therapy for autoimmune disease. And this period becomes very active from a legislative perspective. 1993, the Health Security Act introduced by the Clinton administration, Hillary Care. It collapses under its own weight of complexity. 1997, Clinton administration. The Balanced Budget Act creates Children's Insurance Program, or CHIP, also government administered. It's for children whose parents aren't poor enough for Medicaid but can't afford insurance. And also they froze residency slots. 2003, Bush administration, the Medicare Prescription Drug Improvement Modernization Act that I already mentioned, creates Medicare Part D and advances Medicare Advantage plans, MAPs. And then in 2008, President Obama is elected and puts monumental effort into a legislative vehicle that ultimately passed in 2010, the Affordable Care Act. And while the Affordable Care Act did not achieve universal insurance, it took us from having 16% of the population uninsured to 8% last year. And medicine marches on. And now we're splicing genes and inserting better ones. And common genetic disorders like sickle cell anemia now have a cure. Legislatively, most of what's happened has been to repeal or curtail the Affordable Care Act. Most successfully in 2025 with the One Big Beautiful Bill that decreased eligibility for Medicare Part D, Medicaid, and some types of Medicare. It's thought that, it's predicted, that that will result in 20 million fewer Americans having health insurance by 2034. Why is healthcare so expensive? Because it can be. Because it can be. What happened in the early 1900s with the rest of the world in terms of providing health care for their citizens was an experiment, as much as ours was. The experiment has started to run its course. Now, when I talk to other people, it feels like there's not a depth of understanding about how other countries do this. You could argue that it's not as good, but the data would argue otherwise. You could argue that they ration care in other countries, but I suspect many of you feel like your care is also rationed. One perhaps legitimate registration is that there's longer wait times. So in the United States, it takes longer to see a general practitioner than anywhere else because of the physician shortage that I talked about, especially for general practitioners. It is true that we are the shortest for non-elective surgeries, but we're tied with Switzerland, who you can see a general practitioner in 2 days versus our 21. It feels like people have the impression that this is all done the same way, but there's different flavors for each country. And I just wanted to mention that since I'm on the train of trying to educate. Oops, that's a backwards one. The United Kingdom, the one that gets the most press, a national health service. Whenever these discussions and debates come up, it seems like we don't want that. But here's what that is. The National Health Service is tax-funded universal health care. The government owns the hospitals and owns the clinics and pays the physicians. By the way, they also have a private system that you could buy into with private insurance. But everyone has the access to this. It's cheaper per capita, half as much than in the United States. Their lifespan is 2.5 years longer. It's true that their wait times are longer for non-emergency surgeries. That's accurate. And here's Switzerland, completely different. Mandatory private insurance model. It's universal health care, but it's administered by private insurance. The insurance is highly regulated. If you don't have money to buy insurance, the government will subsidize it. It costs quite a bit more than Britain, $7,000 per capita for Britain, $10,000 for this. But remember, we spend $15,000 per capita. And if we had this, we would save $2.3 trillion in the United States. The strengths are that there's choice and there's access. It's expensive compared to other countries. Remember, their lifespan is 84, as high as Japan, 5 years longer than ours. I asked to come here. I asked because I have 2 goals. One is I wanted to pull back the curtain a little so you could understand how complicated the healthcare system is. Because I have a sense that the complexity keeps people from having an opinion. How do you fix something that's so complicated? I didn't touch all of it. I hope that you're inspired to learn more about it so that it can inform your own opinion. My second goal was I wanted to convey to you that that $5.3 trillion is your money. You don't feel like you have a choice, but it's your money. This is your health system, and it's your government. Educate yourself, get an opinion, and have a voice. Because many of us in this room will have a femur fracture. And in this sophisticated, civilized society, we should all be figuring out how to heal that fracture the best. Thank you.
If you have a question and you've got it on your card, hand it in. Let's see how time goes. We'll start with the written ones. I'm going to use moderator prerogative here. What are medical schools doing? Like, what can medical schools do? One of the issues you said was a shortage of doctors.
Yeah.
And you said plenty of bright kids want to go and become doctors, but can't get into a medical school, or can't do the residency, or can't do.
Yeah. So the issue is not necessarily that the medical schools need to grow or there needs to be more medical schools. In fact, there are more medical schools. The issue is that if you graduate from medical school, you will have to train in a residency. And the residency is the piece that's not changing in size. And so there are little fixes that happen over the years. There is currently a legislative vehicle for adding 14,000 residency slots. I think that was at least alluded to in the State of the Union address last evening. But that is the issue. The issue is we need legislation to allow for more residency slots funded by Medicare.
Insurance companies are allowed to be for-profit, the writer of this question said in the 1970s. Under the Switzerland model, do you know, is that for-profit?
It's, I don't want to get out of my depth. My recollection is that it's mixed, but the difference is that the insurance industry is highly regulated in terms of what they provide.
And following up on that, are you familiar with the French so-called socialist healthcare system? I have a question. The person writes,
I think we have an audience member that would like to speak
the
to that.
person writes that I have had great health care there, even without coverage in their system. They apologize for charging 25 euros for a lab test or a doctor's visit or a prescription. Providers don't believe me when I tell them what the cost would be in the US.
Who wrote that? Let's
Over here.
let's hear it.
Frequently, and I've brought people to the doctors there, and you know, it is a regulated system, but I also know people in the medical profession there. I have family members who are doctors, and they don't complain about it. All of my relatives have had incredible medical care, and even for elective surgery, yeah, there probably are longer wait times, but it's not intimidating, the amount of wait time. They know that it's elective, and it is socialized medicine, and I think that's what we're so scared of in this country. But doctors live really well there. They make a good living. You're not struggling in the medical professions there, and everybody's much healthier and much more relaxed. And one of the statistics I like to quote about the French healthcare system is that people spend only 10% of their income on healthcare. But they spend like 20% of their income on food, and we do just the opposite. So my question is always, what would you rather spend your money on? But yeah, I'd like to know, if you've thought about the comparison of those two systems and how we could do something that would approach that wouldn't be so scary and socialist.
Was that the question at the end? Yeah. Do you want to keep
So
going?
how do we get there, I think is the question. There are these examples. There's the UK, there's Switzerland, there's France. How do we get there here?
Well,
Maybe we don't call it socialist.
we have an answer in the audience. Go ahead.
Well, it is a complex issue, and I'm not going to say that I can give you the answer, but I can say that step one is admitting there's a problem. So I'm glad to see you here tonight, and I think you've helped illuminate what the problems are, where the inefficiencies are. Isn't that a favorite Republican word? Aren't they always trying to get rid of inefficiencies? Well, if you look at the administrative cost of private insurance companies, the last time I checked, the average was over 20%. If you look at the administrative cost of Medicare, it's about 1%, and that includes all the fraud investigation and so forth. So there's 19% of inefficiency right there. So thanks for pointing that out. I do have a couple of other little points. If I get a chance, I'll mention those later. Thank you.
Thank you.
So back to the French question. I don't want to skip that. So I don't want to convey that I know all the answers. An answer to go to something like the UK has would require completely abolishing our system. That's unlikely to happen. And so I think as we conceive of it, the most important thing is we have to understand what we can do that will get us a little closer, which I think is what the Affordable Care Act idea was. We have to understand why things like that failed and where we can go. But I love your point. We have to accept that there's a problem. It's not clear to me that we all accept that there's a problem until we get that explanation of benefits and it's too expensive.
All right, this is sort of a follow-on question. If you were personally to switch the U.S. medical system to another type of system,
knew that was coming. I knew it was coming. I
which
knew it was
would you believe
coming.
would work the best?
Well,
You have a magic wand. What are you doing?
I think, like in all things, there is what would be the best thing and what could we actually achieve. And the reason why I presented the Switzerland model is because it's pretty close to something we could do.
Can we get rid of insurance?
Only if you have a single payer. So that's the National Health Service model.
Just a note that Michelle wanted me to remind everyone that the YouTube stream provides a full screen of the slides. So if you were trying to furiously write down any of that information, it is available if you watch on the YouTube channel.
And if you don't mind, I'm going to say something about the slides for a second. In health systems and health systems management, the most trusted resource is the Kaiser Family Foundation. They keep an up-to-date data repository. And so most of my slides are from there because they're a trusted source in the industry. So, yeah, kff.org. So if you look at my slides or you wanted to go back and get something from the slides, just go to Health Systems Tracker at kff.org. It's quite illuminating.
All right, on to a current event. How will lower vaccination rates among infants and children affect medical expenditure and costs? And what about the impact to adults over 65?
Who wrote that question? It might be rhetorical. What do you think?
I think it's pretty sure that it's going to explode hospital demand, and people that don't have insurance will be bankrupt because they pay the most. So I think it's going to be very costly.
Like many things, it depends, right? So it depends on how low the vaccination rates get for which disease, because every disease has a different requirement for herd immunity, and it depends on the point in time. So most of us have had an MMR, so there will be pretty good herd immunity. Measles is highly infectious. But if that lack of vaccination goes on decade after decade, we'll have huge breakouts of measles. So I asked what you thought because it depends. It won't happen right away. You get pockets of things. And there's lots of things you can vaccinate against, right? So is it a decrease in vaccination of influenza or COVID? And we're seeing, we see increased hospital admissions from that. Mm-hmm. Yeah. It will take time for measles to significantly impact the healthcare system because of our herd immunity. But every year people don't get vaccinated, that becomes more and more risky. But I hate that people don't get vaccinated for measles, just so you know.
What is your view of emphasizing healthier food, more exercise as a prevention?
My view is that has sound scientific data behind it, and I support that view.
All right. Back to the cost of healthcare. How much of healthcare expense is due to lawsuits and litigation? This person writes, malpractice insurance is very high for doctors, for example.
I don't know the exact statistic for that, but I know that it was rolled into that other in the pie chart. I'm sorry, I do not know I hope it's refreshing that you hear someone say, I don't know.
What is your response when someone says, well, we have the best healthcare on the planet? This person says, I do not think we do, but what would your professional answer be to that question?
Look, I'm a scientist, right? I'm a doctor. And so we believe in scientific study, even if it's observational. And the data is very clear that if you measure the best healthcare system in things that are accepted measures like longevity and how healthy you are until you die, we are not the best. The observational studies say that we are not.
All right, this person also wants you waving your magic wand. Are there any changes you would recommend to our healthcare system? Are there and maybe this is not what the person meant, and I'm sorry if I'm putting words in your question. Are there little things we could do? You did mention about the inability to negotiate for prescription prices. Is that something that sort of tinkering around the edge of the system you could see being beneficial?
I think what should be done and what can be done are a little different. I would offer that the prescription drug piece of things in terms of negotiation of prices would be better if it were more competitive. As a patient, you get a prescription and you just go to Walgreens because they're on the corner, but you don't necessarily know that you could get a better price at Publix, right? This is not easy to find or understand. So the transparency of prices and allowing for open competition. I think the concern with the CVS slide that I showed you is that, well, much of the reason, as I understand it, that the healthcare system is the way it is to preserve an open market and competition. And it feels like it's not that. So if we can make things more transparent and competitive, I think that would help. I don't think it's a terrible idea. It's evolved to not being an open market. That's also true for insurance. So I've mentioned before, if you get your dream job and you happen to have Aetna, there's a thought that insurance maybe shouldn't be provided by employers. And that's one of the reasons, because there's not open competition. And another reason is purely an economic one, which is that people stay in their jobs because of their health insurance. And there's a notion that that negatively affects the economy. Yeah.
Does that not also negatively affect people's health? Staying in a job you're not happy or whatever in because you have insurance and you have.
Well, I mean, there's a lot of there, right? It's one thing is job mobility and finding the best job. And then there's this other thing, when I spoke to burnout, there's the checked in and checked out, right? So there's a lot of layers to why that idea of having health insurance be an open market and not employer provided. The reason it's employer provided is because there's tax benefits from your company purchasing healthcare. So they get tax benefits from that. They get a payroll exemption. So if they paid you that same money that they're spending on healthcare, they'd be taxed on it. Yeah.
So I'm a small business owner, and we've always provided insurance, but we weren't required to do so. Because
Yeah.
We always had less than 25 employees, and so we had a choice between Aetna or Florida Blue. So is it just the
You did as an employer, or your employees had that choice?
as an employer, we could pick one, like we could
Right.
pick Florida Blue or we could pick Aetna.
Right.
So are you just saying that the larger companies have to pick one?
No, well, let me pull on that a little bit. So I think what I'm hearing you say is, as an employer, you would choose an insurance company, and then your employees would have that insurance company.
Right, and I could pick whichever was,
You could pick as the employer, but your employee can't pick.
right, we had 3 plans that we would then
Right, but it's all from the same underwriter. Yeah,
either be Aetna or Florida Blue or East.
right. So that is what I'm speaking to, which for an employee seems like not a real open market. They can choose something, they can choose a plan from Aetna, but they can't, as your employer or employee, choose whether they have Blue Cross Blue Shield, United, or Aetna. That's what I'm speaking to.
Okay. Changing topics. Do disparities in the USA make us different? For example, is our life expectancy or the deaths of despair, are those strengthened or weakened because we have such a diverse population?
Disparity or despair?
Both.
Yes,
How about disparities? You touched
So,
on that a little.
I did. So on the life expectancy, actually, we know exactly on average, the years of life that are due to different things. Again, from observational scientific data. And so we know that healthcare disparities, meaning lack of access to healthcare for chronic disease management, contributes 2 out of those 5 years of life expectancy.
Can
But don't
providers,
despair.
yeah. Can providers charge whatever they want?
They can, well, wow, okay. Sometimes I have a brain that thinks of a lot of things at once and I want to say it all. It depends. So if you are a provider and you want to hang up your shingle and you are self-employed and you want to take cash for service, you can charge whatever you want. If you are a clinic or a hospital and you want to take government beneficiaries, you can charge whatever you want, but you will only get paid the government rate. So there's a difference between charge and reimbursement. And the same is true for, as I mentioned, the appendectomy story. You can charge whatever you want, but they negotiate payment, not charge, for all those different things.
I think that was the second part of this question. Is there a difference between charge and actual payment? Are there tax write-offs somewhere in all of this?
Gosh, that's an interesting question. I can't speak to the tax write-off, but I don't think so. Again, like thinking a bunch of stuff that I want to say, and I can't say it all. Prior to the creation of the Medicare Advantage plans, there was a concern, like I said, in the 1970s to 1990s that Medicare would go bankrupt because what was happening at that time was that a hospital, Medicare would pay whatever the hospital said they should pay. So you can have same thing as with insurance, but with Medicare, you can have an appendectomy in New Jersey, or you can have an appendectomy in New York, and the hospital could charge whatever they wanted, and Medicare would pay for it. And so there was legislation that capped the amount Medicare would pay for different things. So there was a time where you could just charge whatever you wanted. And now you really charge what you can be reimbursed. I'm sorry, you're...
No.
I wrote that question.
Okay.
So I just want to clarify. You spoke of EOBs, and I always look at the EOBs, and one that particularly caught my attention was from a colonoscopy, where there was a facility charge of $10,000. The entire cost came to between $16,000 and $17,000, but I'm a Medicare patient, and Medicare paid $1,800 or something like that. So we have a big difference between what was actually charged, knowing who my insurance company was. And so that was my question. Where does that difference go? Is that a tax write-off, or what is it?
I don't think I don't know the answer to that, but
Is anyone paying $18,000 for a colonoscopy? Like, who is that?
Commercial insurance.
Yeah.
Or if you're uninsured. Typically, the uninsured price is lower than the commercial negotiated price. But yes.
Do you have any thoughts on whether the system is controlled by lobbyists? I mean, you mentioned the American Medical Association a few times.
Yeah, so I've worked with the AMA quite a bit, and I regret if it came off as digging at them, but there is a historic reality of their political activism. They've become less politically active, at least on the national front, so I will just offer that. However, they are still very politically active, and they are not the most politically active, perhaps. The pharmaceutical, I mean, it's got a name, Big Pharma, right? Yes, so it's not an opinion, right? There's very influential lobbyists in the for-profit sector of healthcare.
And I assume on the insurance, on every part of it, maybe other than the people in the street.
Yeah, and if you haven't caught it and you are interested, there was a congressional hearing in, I think, December on this topic, on healthcare. You can find it on YouTube. It's very illuminating.
Do you recall who participated in that?
Well, I recall that it was CVS, United, not Aetna, because we already talked about that, Blue Cross Blue Shield, and there was a panelist of 5 that were taking questions, but.
And a regular off-the-street person with their experience of healthcare?
No, it was the CEOs.
All right, I've gone through all of the written questions. All right, one question at a time, keep it short.
Thanks. First, a confession. I've been a health economist for 40 years, now retired. And I really enjoyed the talk, and I'm glad I came, and I think we did get educated. I would like to make a few points that I would take issue with you on. I heard you say that the vaccinations had cured polio, and I don't think that.
Well, eradicated polio.
Okay,
They don't cure it if you have it.
that's right.
I misspoke.
Yes, thank you.
There are
Yes,
now.
there are, yeah. And so that was the main thing, because, if people that are not taking vaccinations don't understand that what they're not getting vaccinated against doesn't have a cure, then that's a whole, kind of experience, perhaps. And I think that's very important in the education of people. They should know the risks that they face. And I'm sure as a doctor, physician, you would appreciate that. The question about, this is also certain political parties like to say, if we just got rid of all the lawsuits, healthcare would be more affordable. So the definitive study on this was done in the 70s, and the numbers haven't changed. I just checked on ChatGPT. So 2.4% of our healthcare costs are attributed to the entire legal malpractice insurance thing, 2.4%. But the study says that more than half of those costs are not because of lawyers, but because of what physicians do to avoid lawyers. They call it defensive testing. So if your patient comes in, says, I've got pain in my chest, and you check and you think, this is my leading diagnosis. My differential diagnosis might be, but you order tests on everything, because if you're wrong, you get sued, and that won't help that's a very simplistic view of it, but that's what defensive tests means. You order tests that you probably don't think are necessary, but you should. Maybe you'd like to argue with that, but that was in Martin Feldstein's 1976 paper on when he broke down the cost of medical care, and nobody has come up with different conclusions in the field yet.
Is there a question?
No, that was people wanted to know what the picture was on defensive medicine and legal costs. So that's the answer.
As someone
you.
who went to law school, For once, we're not blaming the lawyers. Sorry, doctors. Any other questions from the floor?
Thanks a bunch for breaking this all down for us. And I'm sure what a lot of it is, at least for me, you're telling me really in-depth things about this system that, you know, it's not encouraging seeing that it's going to change at all. You know, that the one-payer health system was, I remember Bernie Sanders just being all about that, right? And there was a certain person that, or a certain group that really rallied behind that. But then, given the climate of the country, socialism, socialism, even though it's for the benefit of so many at the cost of profit of so few, you know, that are profiting by the system that's in place. And I guess that's why is there such a, I mean, it's such an ambiguous and almost like, you know, it's a system that the doctors don't know what the insurance is doing, and that the insurance doesn't really care how efficient they are in providing this care. Like, and the point I'm going to make is about in-network providers, how they print out these books and say that this is going to be covered by whatever insurance company it is, Aetna, Blue Cross, you know, United Healthcare, whatever. But then the doctor has the last-minute option of saying, no, we don't take that plan, even though insurance companies are telling you, yes, they do take the plan. And we're sitting in here getting push me, pulled me on all kinds of things, and the burden of everything ultimately falls on us. Even if we do have insurance, whether it's high quality, low quality, whatever else, we're the ones that got to do all the investigative work. And yet there's also such a incestuous relationship between big pharma and doctors. How many times do you see, you know, they're coming in there trying to pitch doctors on using their stuff? So, I mean, it's the bottom line is it's all a money grab, and as long as the people that are profiting continue to profit, they'll put up the roadblocks to make us suffer. Yeah. I'm sorry to be a downer on that, but, and I don't have a question, that's all I have.
But just to follow on that, though, one of the things you talked about was time that gets spent on, you know, your patient, you want to do X and they can't get it cleared and it needs to go through. Do you have an estimate of how much sort of time, which equals money, in
Do you
your
mean
practice you spend on?
wait time?
Not really wait time, but more just on trying to get a patient to be able to get the prescription they should or the procedure they should.
So first I have to say I cannot talk about my employer.
Okay.
So I won't be able to answer that specifically to my practice. And I also can't answer that in terms of time or money, other than it seems like a big burden on everyone.
That some percent of your day is spent at the end of the day dealing with those types of issues.
Some percent of somebody's day,
Yeah.
right? Because depending on the healthcare facility, there are folks who are employed to do that. But then there's a burden on the patient, as this gentleman said. And sir, I appreciate your comments, and I heard that there's not a question, but I think that there's a marching order for you, right? And for you and you to understand and then to use your voice. You have some folks here who are hoping to be your representatives. Tell them what you think. Go.
Oops.
What happens to all the employees of the insurance companies? Like, what happens to Hartford, Connecticut? Or whatever. Is there any role in the new system? Or are they going to be all dislocated? And
Good Lord. I can't answer that question for you.
okay.
You know, that's why before I said that you can have a concept of what you wish things could be, and then you will have to confront the reality of what could happen in the United States. The reason the national health system can exist as it does was because it was built that way from the beginning. We already have a whole healthcare system. And I don't know what would happen to the Hartford and Connect if we went to one. Yeah.
Possibly answer that. Medicare doesn't literally pay your claims. They don't have a bunch of claims processors in Washington, D.C. They So to piggyback on that very rudimentary understanding so I work for a health insurance broker. I don't know if I should say that too loudly, but, but like in England, they still have supplemental coverage. So you still would want the life insurance and maybe upgrade your dental insurance and maybe get a better vision plan. So there would still be room in the market, I think, for those things, even if we go to a single payer type system. And then to touch on a point from earlier with your Aetna slide, so not only is Aetna involved in that, but you're going in there to get your prescription, you're probably gonna pick up a soda, you might buy a candy bar, and you also might need some hairspray or some milk. So they gotcha.
Thanks. The slide that you showed on per capita expenditure per healthcare, if you look at it again, I can tell you something important that I don't think came out. And that is all the other countries, maybe with one or two exceptions, it covers everybody in the country. The United States and New Zealand are the only two OECD countries, that's the top 18 economies in the world, that don't have universal health care. So even Thailand, where I spent a lot of time, and South Korea, where I was a Peace Corps volunteer, when I first lived there, they didn't have national health insurance, but they do now. So those expenditure figures, remember that, not everybody is covered in the United States, but that's the price tag they pay for insuring their entire population.
Yeah, that's a great point. Thank you. Yes, ma'am.
I just have a quick question. When did the pharma companies' marketing change from giving pens and pencils and notepads to the physicians to bombarding us during the nightly news? And how did that happen?
1996.
How did that happen?
I don't know.
It was illegal to advertise in magazines,
Oh, yeah.
radio, and the FCC rule was abandoned in 1977, the precise year. I might be off plus minus 1 year, but because I was in grad school when it happened, and everybody was so shocked. So before that, you never saw those ads. And they couldn't come on TV and tell you about Offenza or whatever that was, a catchy logo. It was illegal. Right? And by the way, would you say, I have a question, does that add to the cost of pharmaceuticals when they spend,
Yeah, well,
$20 billion a year on advertising?
they put it in the research and development budget, but yeah.
Well, I think the list you have up there, I mean, all of us probably know what you would need to have to take Eliquis, Jardiance, Xarelto, Farxiga. I mean, you get bombarded with them.
I don't know the answer to that, but I know it's variable from one healthcare institution to another. They all have their own rules about that.
Awesome. We're getting a little bit to technology in healthcare, and my question kind of follows along this. From your perspective, how much has changed with regards to AI and with regards to denying claims and the cost of healthcare with regards to AI being introduced into the claim service?
I don't have an answer for that, and that's not where I thought you were going.
You could answer where you thought he was going.
I thought you were going on a topic I like to think about, and it hasn't happened yet, so we don't know. But I thought you were going to how much of the provision of healthcare could be done by AI. And we're all grappling with that. Some portion.
Are you saying that it's not used already in radiology?
Oh, no, I didn't say that. It's 100% used. Oh, yeah. Yeah, it's, again, a whole other topic. Something that is being grappled with in healthcare is how to get paid for AI. Because if you could predict that AI could administer at least some portion of healthcare, how would you get paid for that? And that is my ballywick actually, and there's a lot of there, and it'll get boring. But I think there is a question and perhaps a hope that AI would reduce the cost of the administration of healthcare.
All right, how about parting words? What do you want us to leave here and do?
Well, I said them already, but I'll say them again. Be interested. It's complicated. Try to understand it. And then get an opinion and use your voice, right? Because it's yours. Don't just take it. Yeah, so that, were you going to say the same thing? Yeah, kff.org, KaiserFamilyFoundation.org. It really has a deep and wide repository of not just data, but articles. They're coming out all the time. It's really a great resource. That would be the single best resource, I think.
Great. All right, well, on behalf of everyone, let us give Dr. Francis a round of applause.
Thank you.